we move on to the next talk titled The Filtration Station, Optimizing Anesthetic Management During Kidney Transplantation. We are pleased to invite Dr. Tippaswamy Edgy, Associate Professor of Anaesthesiology at Yenapoya Medical College, Mangalore. Let us now welcome Dr. Tippaswamy Edgy, sir, to enlighten us on this critical topic.
Good afternoon, chairpersons. Good afternoon, audience. I think post-lunch session. So I hope I do justice to not make you to sleep. This is topic for the day is anesthesia for renal transplant surgery. So it's very difficult to finish in 15 minutes. I'll just go through some salient features. This is medical college where I work. This is the roadmap. I'll just skip this. It's okay. Historically, I think 1902 we started the renal transplant with xenograft. Started with pigs and started. And Joseph Muller was the main person in 1960s. First successful transplant done in 1960. So in identical twins, which was more successful. And in India, first was done in CMC Vellore. From then we have moved on. And I think renal transplant is the most common transplant surgery done nowadays. So I always wonder why RCB couldn't win for 18 years. So I thought that because I think everybody was playing individually. There was no team effort. So the last time we won because of the team effort. So transplant success depends upon the team effort, and anesthesiologists being sometimes Virat Kohli or sometimes Azad Patidar, okay? So I'll skip this evaluation. Okay, now the preparation and the transplant. You always see the Usain Bolt performing for the just 8.5 seconds in the marathon, in the sprinter. But what it takes is how much behind the scene he works. So the transplant anesthesia is same, especially in the renal transplant. How much you work and how much you prepare for the patient, it makes the successful outcome rather than on the day of the surgery. On the day of the surgery, it's nothing. Take a graft and put it, do anastomosis and come out. Evaluation, madam, my previous speaker has told very well about the CKD, ESRD patients and things. So I just want to skip this and directly go to the important evaluation. So in this, why I put this is, there is an AHA recommendations of, especially for the cardiac evaluation. See, either an ESRD patient coming for any surgery or a renal transplant, the major outcome or the mortality is related to cardiac event. So the cardiac evaluation becomes a prime importance when you do. So if the patient, say something like a 20-year-old patient coming for surgery without any comorbidities, a cardiac, directly you go with the non-invasive cardiac stress testing. But if he has any other condition, something like a risk factors of LVH, or he has a chronic, any dialysis more than 1 year, or a greater than age of 60 years, diabetic, then you have to go for the invasive cardiac testing. So next important thing is transplant patient who having a pulmonary hypertension. See, the pulmonary hypertension becomes it is a static, and also it keeps on increasing as the dialysis increases because of the ESRD per se. So especially the hypertension, the pulmonary hypertension, if it is severe, so it becomes a contraindication per se. So mild to moderate becomes a very good indication, and the moment you do a transplant, these patients tend to improve. And if it is combined with the biomarkers, nowadays we use a tropi also. Combined with that, we evaluate for the CKD patients. Coming to the cardiovascularization, LMPCI, what we call it as, in asymptomatic patients, there are enough of trials like CARP trial, COURAGE trial, where they found out that you don't have to do in asymptomatic patients revascularization. But in indicated patients, according to the ACC guidelines, if you do a vascularization, it is more beneficial. Okay? So this is what I was telling with CARP trial, and there was no benefit. Okay, and next important is about the peri-op medical management with the beta blockers. So as it holds good for other beta blockers, don't start on the previous day if you want to start on beta blockers. If already on beta blockers, or if the patient requires a beta blocker because of other indications, you have to start. So coming to other evaluations, pulmonary, as madam told, we usually evaluate with X-ray at PFT. In diabetes, mainly you evaluate also for atherosclerosis and C-peptide, mainly to see the feasibility of simultaneous pancreas and kidney transplantation. Obesity, if BMI is more than 35, we generally tend to go for the bariatric surgery first and then followed by the transplantations. In GIT, the recent data shows that hepatitis B, A, C are not a contraindication. But whereas if acute infections are there like cholecystitis, better to treat and then take up for the transplant. And if it is gastric peptide disease and all, better to treat. In urology evaluation, left to urologist, but we always tend to see for the native nephrectomy and bladder functions because post-transplant, they are the main reasons for the DGF, delayed graft functions. So infections, they have to be given all the vaccines like pneumococcal, influenza, what. And in the USA, we always do a pregnancy test is indicated. So what we do as a pre-transplant preparation, so dialysis, immunosuppression, and glycemic control or anything, and bridging with heparin if needed. So this is what we follow in our hospital. So the 1 day prior, that is 21st prior, we do for CDC, that is complement activated cross match. Then again, we go for the repeated pre-op investigations once it again, because we would have taken a long, prepared for a long time. Then glucodepleted PRBC will be kept ready, and usually we improve the HB till 10. That is usually the target, but sometimes we may not achieve it. So dialysis will be done on the previous day. Higher antibiotics, we usually use piperacillin tazobactam, and we start with that. You have iodine scrub and post-HD investigation just to see in case HD is done properly or not. And we start with immunosuppression and induction. That varies between the patients and immunological criteria. Sometimes we start 1 week before, sometimes we start on the previous day. And pre-anesthetic medications hold good as per any anesthetic advice of any other surgery. Coming to what you do on the surgery day, so historically, in 1901, when they started, usually they started with spinal anesthesia itself. So Joseph Muller, I think he started with spinal anesthesia as a transplant. Then we have a spinal epidural you can do. So even the transplant anesthesia, Padmanabha sir is there. We have done many cases with spinal epidural also. But now we go up with general anesthesia with endotracheal intubation. So as madam already covered in detail about GA, so I don't want to go in detail, but I feel that these are the holds good with the drugs. So it basically, the art of giving drugs and what you use and how you use depends the outcome rather than what you use. So we in routine, we use propofol for induction, and etomidate we have reserved it for the patients with a poor cardiac reserve like EF somewhere around 30, 35 or less. So opioids, remifentanil, I still didn't get. It has, even though it has launched. So fentanyl we are still using. Muscle relaxant, we use Cisatrac more frequently than Atrac. Inhalation, fortunately, we have this, we use more often. And ISO, sevoflurane, as they told with the high flows we can use, but there is no human studies to say that sevoflurane induces fluoride toxicity yet. So reversal agent based on the agents what you use. So as madam told also, like invasive lines is part of a renal transplant. So very importantly, AV fistula care, because immediately if the kidney doesn't function, so you need to see that the patient has to be taken up for immediate dialysis for the better outcome. So AV fistula care becomes very, very important. Then wide bore cannula, if possible. It's most of the time it is not possible. So what we routinely do is we take with the peripheral lines and immediately go for the central line, ultrasound guided central lines. But take it from me, theoretically it looks easier, but practically we have faced difficulties even putting a central line because these patients would have been dialyzed for a longer time with the HD catheters, so which are put on usually IJV right and IJV left, sometimes in the left IJV. So there will be a thrombosis already. So when you go for the, again, cannulation, it will be very difficult. So pre-operatively, please scan and be ready like where you want to do a vascular access and IBP as a routine because too much of BP fluctuations we do. So this is the routinely we do, and we have used Swan-Ganz catheters and also transesophageal echo for 1 or 2 patients with the help of a cardiac anesthetist. So what monitoring? There is a huge journals, publications on how to monitor. And this monitoring basically to monitor the blood pressure and perioperative fluid therapy. The standard ASA, CVP and IBP, and CVP is now obsolete. I think nobody advises CVP because of many factors, and IBP is still a standard. TE in selected patients, but TE, as it is a cumbersome and it's not continuously monitorable, so we still go less with the TE. And cardiac output monitoring, especially non-invasive cardiac output, becomes a very important tool. And more than a static, we go for the dynamic analysis. This is what we want to do. Like nowadays, we have the good machines, the good monitors to go with the pulse counter analysis. We go with that. We have enough of studies to support SPV, that goal-directed therapy, that is SPV, SVV, are more than enough to go with the renal transplant outcome. So this is about the monitoring, and go for the fluids. So there is, again, enough of evidence to say that the balanced salt solutions makes a good fluid of choice than normal saline or other things. So normal saline, even though many people tell that RL has a potassium and normal saline doesn't have a potassium, so hyperkalemia is a risk factor. But normal saline, it is no more normal. It's an abnormal saline, mainly because of the chloride content which has. The chloride which causes the acidosis raises the potassium very much more than what we use as a balanced salt solution. If you use a balanced salt solution, like a 5 milliequivalents which you use in 1 liter, probably it raises potassium by 0.1 milliequivalents per liter. Whereas this NS, if you use the causes acidosis, it can raise a potassium by more than 0.5 to 0.6. So for acid-base balance, gastric perfusion, even hemostasis and renal function, it's better to go with the balanced salt solutions. And coming to the colloids, we preferably do not use colloids, but if indicated, albumin has a better strategy to use colloids. So this is just a busy slide to tell that what are the things we used to from, say, for example, 1982 to 2015, what are the monitoring strategies we use for the better outcome. So if you see this carefully, so we started with pulmonary artery pressure changes, like less than 20 to more than 20 as a marker. And then we moved on to use CVP, then we moved on to use the MAP, mean arterial pressure, then SVV and CVP, until the transesophageal echo. That is how the monitoring has evolved. And basically nothing much has changed in the graft outcome. So use of loop diuretics and mannitol, again it is inconclusive. Mannitol is tried, and we still use mannitol, and especially before just the graft is opened, that is anastomosis is done, released. And low dose dopamine, many centers use, we don't use. And alpha adrenergic receptors, which doesn't act, especially vasopressors, that has a better outcome. So this one journal I had come because of the single fact that this Max A. Levine, the author, has published a series of articles in this CJ, that's Canadian Journal, where in 2015, 2018, there he was postulating that mannitol or low dose or loop diuretics were not effective. But in recently 2024, again his journal only, he told that mannitol is of some value. So I think mannitol and loop diuretics still you can go. So analgesia, we use short-acting opioids, fentanyl infusion, ESPB, QL block with TAP block, Dexmed infusion, and it's multimodal. Multimodal you can use with TAP, with Dex, with paracetamol, like that. So there is so many papers put it on Dexmed itself as an intraoperative analgesic and post-op. So they have found the better outcome with dexmedetomidine. So we generally not use dexmedetomidine so much, but we use the other analgesics. Again, this is about delayed graft function. So whatever it is, delayed graft function may be whatever may be the reason, the anesthetic conduct also plays an important role in the delayed graft function. The ATN will be the most common cause of delayed graft function, this ischemia reperfusion injury. The use of mannitol was mostly advised for the ischemia reperfusion injury and other things. So these are the predictors, that is old donors, genetically unrelated donors, high recipient body mass index, pre-transplant dialysis. All these are the risk factors, predictors for the graft function. So in optimizing graft function, so pre-op optimization becomes very, very important. It's like preparing the patient, the good dry weight. So in our setup, we go with a decreased dry weight. That is, we go over dry weight. That is, we do 2 to 3 liters of dialysis rather than the underweight. So again, there are studies to say that what is like whether you have done a more dialysis, like ultrafiltration more to the normal. So there is not much of changes with the studies. This is biphasic fluid therapy, what we use it. Like before still we go till the anastomosis initial, see the target CVPR at 5, 6, and when you go for the anastomosis, increase the CVP to 12. The moment they want to release the clamp, your CVP should go about 12. That has a better perfusion. So balanced salt solution, dynamic variables monitoring, and keep a map above 90. That is what it is very much needed, the mannitol and multimodal analgesia. Thank you.
Thank you, sir, for that focused and practical overview of renal